I think it's simple ciliated columnar cells.
Okay, so this is you're talking about the respiratory epithelium.
Yeah, in the airways, not in the alveoli.
Okay. Anyone else?
Is pseudocolumnar ciliated or ciliated? Certified? Yeah,
Yes.
Abdul
Okay, very
mentioned
good.
in the chat.
Yes. Yeah. So it is pseudostratified. Yeah. Pseudostratified tall columnar ciliated epithelium. This is mostly we found in the conducting zone. So this is when we say respiratory epithelium, so we mean that we are talking about the pseudostratified layer. Yeah. It is ciliated. We know that conducting zone ciliated, so the particles has to be rejected out. That has to be ciliated. Yeah. It is pseudostratified, so it looks like stratified, but they are not stratified. But when we talk about the nose, so what is the particular addition points for the nose in the epithelial lining? What should be?
Ciliated?
Ciliated, we have it in the conducting zone, other than ciliated.
Abdul mentioned it. Keratinized.
Keratinized, very good. Keratinized. Why? Because we know that every opening of the body has a connection with the outside of the body, with the outer environment. It has to be keratinized to protect the lining from the bacteria and others. So the nasal cavity part only, it has keratinization, like oral cavity, like anal canal, yeah? So the openings, they have keratinization. This is only the part where we find the keratinization. Otherwise, the rest we have for the conducting zone, that is pseudostratified tall columnar ciliated epithelium. Very good. So we know that one thing point here is that as we move from the nasal cavity toward the lower part of the bronchioles, the type of the epithelium keeps on changing. Yeah. So start by pseudostratified, then the stratified, then we're coming down to columnar, cuboidal, then it's to the small or simple squamous epithelium where we have from the respiratory bronchioles, because for the gas exchange, we need the least layers for the gas exchange. So start from pseudostratified, columnar, ciliated, then non-ciliated, then coming down toward the cuboidal, from cuboidal toward the simple squamous epithelium. Yeah. Type. Now, what else we found in the conducting zone but cannot be found in the respiratory zone?
Goblet cells.
Goblet cells, very good. What is the function of goblet cells?
Secrete mucus.
Secrete mucus, very good. So we know that in the conducting zone, while the air is coming inside the body, it has to be moisturified. It has to be warm. So for this, we have the mucus secretion by the goblet cells. So we have abundant number of goblet cells that could be found in the conducting zone as in the comparison of that. And it is absent, in fact, in the when we go down toward the respiratory part or respiratory zone. Yeah. Very good. This is the second part that we have goblet cells. What else we found abundant or high amount in the conducting zone, but not in the respiratory zone? Or that disappear in the respiratory zone? Yeah.
Cartilage.
Cartilage, very good. So the cartilages keeps in decreasing in the number and amount starting from or merging from the conducting zone, upper conducting zone toward the lower conducting zone, then toward the respiratory zone. So the amount of the cartilage in the lower respiratory zone, even in the lower conducting zone, will be less than the upper part of the conducting zone. So cartilage keeps on decreasing. Yes, very good. What else?
Can we say Clara cells?
Clara cells. Clara cells keeps on increasing or decreasing as we move downward?
Decreasing.
Are you sure? So what is the function of Clara cell?
Surfactant?
Huh? Yes?
Yes, stem cell surfactant.
Surfactant. So surfactant, where we find more?
Okay, respiratory zone.
So, and this surfactant and or chlorophyll contributing with the function, which type of cells?
Pneumocyte type 2.
Very good. Pneumocyte type 2. Yeah? Or pneumocyte type 2. Pneumocyte type 2, we know that is the second type of cells that's found in the respiratory part, and that's contributing in the formation of surfactant. Yes? So this is actually where we found in that. Very good. So chlorophyll is increased as we go down because chlorophyll is also contributing and formation, or with the help of the function of pneumocyte type 2, which help in the formation of surfactant. Yes. What else that keeps on decreasing while we're merging from the conducting zone to respiratory zone?
Smooth muscles.
Smooth muscles. Very good. Smooth muscle, they also keeps. So as we move downward of the conducting zone, we almost miss the cartilages, but we get only smooth muscles downward. Yeah, very good. And yes. What else? What else that while we move from the conducting zone to respiratory zone also keeps disappearing?
Club cells.
Please.
Or is
Sorry?
it the other name? Club cells, or is it the other name of Clara cells?
That is the other name. We talk about the cilia. Cilia also keeps disappearing, yeah, from the upper and lower zone. Yeah, and just for an addition point. Very good. So yeah, great, mashallah. So we almost covered, let's say, 70% of the histology of the respiratory system. So these are actually the points, the important points that need to be kept in mind. Here you see the presentation of the cells. Yeah, they're like overlapping each other. This is actually explaining the how the presentation of pseudostratified. Yeah. So the irregular shape of the cells. Then we talk here about the goblet cells. Yeah. These are the goblet cells, glands secreting. See, this is a secretion of the mucus going out from the goblet cells. These are the brush layer. Yeah. The brush cells, whatever, cilia. طيب. We know that the trachea is made up of tracheal ring. They are the cartilages. Tracheal ring, it's actually to keep the passage, the conducting zone open always, not to be closed. So the trachea then downward itself is divided into two main bronchus. Yeah, this area here, where the bifurcation takes place, we call it carina. Now this bifurcation takes place at what level of the sternum?
Sternal angle.
Sternal angle, very good. Or we call it angle of Lewis. Yes, very good. That at which level, or at what level of the vertebrae?
T4, T5.
T4, T5.
Yeah, between them, between 24 and 5. Very good.
T4, T5.
Right. Left, he's talking about the left bronchus. Left bronchus, definitely we know that left bronchus divided into two, yeah, because we have two loops. And the right is for three loops, yeah, so three parts or three branches in the right as in comparison to the left. طيب. So here they are talking about actually the division of the bronchioles. They're talking about almost 10 division on the right side and 8 division of the bronchioles on the left side. Yeah, so to cover the most area of the lung. So he's talking about this complex system of the bronchioles that transport the gas from the trachea downward to the acini. When we know that the alveoli itself, because they are sac-like structure, so they call it acinus. Huh? So acinus is nothing. This is actually explaining the alveoli itself. That is where the gas exchange takes place. Here they're saying like this bronchioles or bronchial system, they are formed into generation of dichotomous, yeah, dichotomous branching. What do I mean by dichotomous branching? How we could define
Maybe
dichotomous branching? Yes.
Yeah. Each branch will branch into two bronchioles or two.
This is actually dichotomous branching as a terminology. What they mean by this is actually, they are saying it is about a complex process. So this is the process where the division takes place. So this is a complex process in which control the morphogenetic division of the bronchial system. Yeah. So the morphogenic, when this term morphogenic means the morphology, the shape, and the genetic. So we mean by this that they have a particular way to divide, unlike other division. So they have a particular way, particular division, particular directions, and the number of divisions. Yeah. So they are in a morphogenetic division that takes place during the division. So it has a particular complexity of division. Is that clear what we mean by dichotomous branching?
Yes, doctor.
Very good. So it's nothing. It's just explaining that they are actually dividing in a particular manner to make the shape and the genetic distribution of the bronchial system. Like extended from the trachea downward to the bronchioles, and yeah. So from the trachea to terminal bronchioles, the airway respiratory conducting pipes. So you don't have to remember the numbers, these numbers, yeah. So that's why you see that I'm skipping this, because we don't have to go into this much, like to know about how much generation. Yes, we have discussed, I think maybe in first year, if I'm not wrong, about the bronchopulmonary segments. We said like we have 10 segmentations in the right and we have 8 in the left. So just only this, we don't have to know about how many apicals, how many anterior, superior, etc. We don't have to know that. So
Nice.
yes. So the airway are pure conducting pipes. Yes, we discussed about that, and we said like about the dead space has almost 150 ml. Yes, and so bronchioles for divided to alveolar duct. Yeah, okay. So this is about this part. So here is again just explaining what we have already discussed. Actually, I pretend myself not to go through the slides to read other than we discussed, because I know you know it. So that would be better than only reading. So these all information we have already now discussed in the first slide while we were interacting with each other. Now, if you see here, if there is anything important to discuss, pulmonary circulation consists of capillary pump, consists of cage. Yeah, here talking about the phenomena of the respiration, that we have pulmonary circulation where the gas exchange takes place, and we have ventilatory pump by the mean of the movement of the thoracic cage and respiratory muscle, yeah, and the elastic tissue of the lung. So these are working as a mechanical pump for the ventilation. So thoracic cage, definitely movement of thoracic cage with the diaphragm, We are talking about the respiratory muscles, which helping the movement of the thoracic cage. And we talk about the elasticity of the lung, which allow the lungs to expand and recoil to return back. Yeah. So we know that the lung, it has high elasticity, which allow the lung to expand and return back simultaneously by the phenomena of recoiling. Yeah. Like we have the cartilages. If you remember the cartilage, the elastic cartilage, like for example, the outer ear, the outer ear, it has a phenomena of recoiling. So whatsoever the shape you do it, and if you move your hand, so it will return to its normal position or normal shape. Yeah. So this is again also this type of features we can find it in the lung as well. It says here conducting zone warming, moistening and cleaning. Yeah, we have discussed this. Okay. So here it's talking about bronchial tree is strongly ramified. What do you mean by ramified?
Ramified? Maybe
Yeah,
Dr.
ramified.
Like it's having many branches. It depends on branching.
Yes, very good. So ramify is nothing. That means ramify means branches. So it's like so bronchial tree is strongly ramified, means strongly branched, has a branching pattern. Yeah. So it's mentioning here ramification pattern means branching pattern. So we know that it is highly divided. So talking about the bronchioles and okay. Yeah, so you see here the things that keeps in disappearing while moving from the conducting to respiratory zone. Yeah, so goblet cell, as you see, goblet cells, they are keeping in disappearing, ciliated glands, cartilage, smooth muscle, and elastic fibers. As we move down, they keeps in decreasing. So it's the same. It's talking about the structure again. Contraction of a smooth muscle also reduces the diameter of the airway. Yeah, let's see what it says here. It says like the elastin fiber are stretched to the point where the shifter collagen fiber restrict the maximal stretch. Yeah, one thing here is that that's also the elastic fibers prevent the extra or excessive or unneeded expansion of the lung. Yeah, so this is another function. Contraction of the smooth muscle also cells also reduce the diameter of the airway. Yeah, so we have we know about that bronchoconstriction. Yeah, where the medium and medium lower part of the bronchioles where they constrict, particularly in the case of asthma. Yeah, we know that. So here they're talking about the cell, what we have mentioned, the contributing information of surfactant, pneumocyte type 2, surfactant, and anti-inflammatory effect. طيب. You talk about the alveolar duct, then alveolar sac or alveolar sinus. Yeah, the same. You talk about the alveoli itself, where they're saying like each lung has almost 1.5 to 2 million of alveoli. That helps in the gas exchange. There's another presentations. Now this need to be open completely. So we see here. So we know that here, let's read quickly about this. So it has good information. So it's saying about each branch of the bronchial tree eventually subdivided to form very narrow terminal bronchioles. Yes, we know that, which terminates in the alveoli. There are many millions of alveoli each lung, and they are irresponsible of gas exchange. Yeah, we discussed about that. Each alveolus is very closely associated with the network of capillaries. Yeah. So each alveoli has a network of capillaries which allows a gas exchange from where the deoxygenated blood comes toward the lung to the level of alveolus where the gas exchange, carbon dioxide goes out and toward the alveoli and oxygen goes in to have it. So now the question that this deoxygenated blood coming from where?
Sorry, doctor.
This deoxygenated blood coming toward the alveolus coming from where?
Yeah.
Yeah, pulmonary arteries, yeah? Coming from pulmonary, very good. So the capillary then allow with the thin layer, we'll talk about the respiratory epithelium or respiratory exchange layers. Next slide. So this thin, very thin layer allowing the rapid gas exchange by passive diffusion, yeah? With the concentration gradients. So high concentration to lower concentration. Carbon dioxide moves into alveolus. Yeah, we have discussed this. Nothing important here. So here we are talking about the layers. Huh? So this is the alveoli, and here we have the capillaries surrounding the alveolus. Yeah, capillaries, they are coming from the pulmonary artery into smaller arterioles. Then we have the capillaries reaching the area of the alveolus. So we have the epithelial lining of the alveoli, basement membrane. Yeah, basement membrane definitely, because epithelium need to lie on something. So we have a basement membrane. Then we have here the capillary endothelium. So these are made up of 3 layers. Yeah. So here the same. This is capillary. This is alveoli. So we have epithelium. We have basement membrane. Then we have the capillary basement membrane or endothelium. So that means we have only 3 layers. So that's why we have gap junctions with the carbon dioxide and oxygen. They move from either side by the mean of diffusion. Now here is talking about the bronchus. The right bronchus, it is wider. Yeah, the wider. So what is the consequences of the right to be wider? That's if there is any aspiration, so that goes toward the right side as compared to the left. Why? Because right side is wider. We understand, yani just make common sense that since the right side it is bigger, so we need a wider bronchus, yeah, to give more oxygen in comparison to left side. So it is wider, so it is more prone to have an aspiration there. So if there is an aspiration, that will affect the right lung. Also, the right bronchus is divided into upper lobe branches and bronchus intermedius continue before dividing into middle and lower bronchi. So yes, so this is an important clinical point that they say that on the right side, does not divide immediately simultaneously at the same level at 3 branches, 3 bronchus. Yeah. So right will divide into first in the upper lobe branch. Yeah, the upper lobe branch. Then it has intermedius which goes down, and then this intermedius divided into 2. That's for middle and lower lobe. What is the consequences of this? The importance of this is that they say like whenever there is a foreign material, yeah, engulfed by the mouth or masses, they will collapse the lower and middle. The middle and lower lobe. Yeah. So when we talk about the middle and lower lobe, so we talk about the below the horizontal fissure. So, and if you say like there's a mass, or if there is a foreign material found in the below the horizontal fissure, right lung, definitely it should be right lung because there is no horizontal fissure in the lung. So which lobe we are talking about? If it is below the horizontal fissure?
Middle and lower.
If we say, yeah, middle. If we say it is below the horizontal, so it will be middle. If you say, in the right below right oblique fissure, so it will be in which lobe?
Lower.
And if we say it is on the upper or above the left fissure,
The left fissure, I think it's the right upper lobe.
left upper lobe.
Left
And if,
also.
yeah, and if, and if you say this mass is found upper in the upper of the right oblique fissure, so it will be in which lobe?
Again, doctor?
Middle. Again, if we say that the mass is found above the right oblique fissure, so in which lobe it will be?
Middle.
Middle, yes, definitely. Middle, because we said upper, not lower. Yeah, so it will be in the middle. واضح؟
واضح.
ايه دكتور.
جيد. طيب. So here's the second point saying like the bronchioles are not maintained by cartilage. They contain, yeah, this is important. That's bronchioles. Yeah, lower part of the bronchioles, they are not maintained by the cartilage but the smooth muscle. So when they constrict, makes like bronchoconstriction. This will small the airway constriction to form the basis of asthma. So this is what happened during asthma. So the lower part of the bronchioles, they constrict, make bronchoconstriction. That's why we give bronchodilators, yeah, to relax the smooth muscle, to prevent the constrictions. So this is about this lecture today. It was a kind of revision about the anatomy and histology of the respiratory system.